you're looking at our slides, we are officially halfway through our slides. So we were talking about compensatory mechanisms, so now we're going to talk about chronic compensatory mechanisms, which first one we'll talk about is this concentric hypertrophy. Kind of think of this as the muscle fibers, the sarcomeres get stacked. So here's your visualization of that. So you get a stacked appearance to the sarcomeres. So it gets an overall stronger muscle, which allows it to deal with excess pressure. So be thinking of this in your HEF patients, where you get, because of that extra pressure, they increase the left ventricle, you get that left ventricular hypertrophy to get a more powerful squeeze. As opposed to conditions that cause a ventricular dilation, where you get this eccentric hypertrophy, which is basically you get the sarcomeres put in series to make that muscle fiber longer to be able to handle that dilation. And it's to help you deal with excess volume. So be thinking of this in your HEF-REF patients. So it allows, hopefully you'll be able to get a better squeeze by doing that, because they're not getting stretched out so far that they're losing their function. So you basically are kind of restoring that Frank Starling mechanism of that curve. And unfortunately, because the Olympics do start tonight, you're not going to be able to watch them. Here's your so again, with the remodeling, that you get concentric hypertrophy and pressure, you're gonna see this hypertrophy, which is going to reduce the flexibility, kind of the ability to the compliance of the ventricle. So it's not going to be able to handle much volume before it fills up. Whereas with eccentric, because it's doing, trying to dilate longer or wider to be able to handle that extra volume, you're going to kind of get a much bigger appearance, a wider appearance of it to try to restore some function. But ultimately, that extra volume, you lose contractility, so you lose that cardiac output. So. Then we talked about acute decompensated heart failure, which was basically somebody who has heart failure and then they just acutely worsen. And there's a lot of different triggers for it, so the acronym HEART failed. So basically just think of, there's something outside of the heart that's impacting the function acutely to the heart. And they're going to get the acute symptoms. So if it's a left-sided problem, so you're going to be seeing pulmonary problems. If it's the right side, you're going to be seeing kind of the things in like the edema in the legs, the JVD, or abdominal kind of symptoms, just from that extra volume kind of being placed in all those different areas. So, and recall that the most common cause of right-sided heart failure is left-sided. So it is very common that you're going to see left-sided symptoms and right-sided symptoms. And those are your symptoms that you're going to get for the left and the right. The natriuretic peptides, BNP, pro-BNP, these are great tests that you can do. These are blood tests that you can do to help you differentiate cardiac dyspnea from pulmonic dyspnea. So allow you to kind of see if this is the lungs that are the problem, or is it the heart that's the problem that's causing the shortness of breath. And recall that the natriuretic peptides are actually a good compensatory mechanism where you're trying to restore homeostasis. Typically, both of these peptides, they don't circulate around in the blood when the heart is functioning normally. So if the heart is functioning abnormally and you start to get a stress or a stretch of the heart, that's when these peptides are released. So that's why the normal for a lot of folks is basically undetectable. What else are you going to see on your ancillary studies with acute decompensated heart failure? Well, you're going to see the pulmonary edema. You're going to see the heart size itself being impacted. Your echo is going to be your test of choice. It's going to be able to tell you exactly, is this diastolic dysfunction versus systolic dysfunction? What's the EF? What could be causing this decompensation? And then we talked about the classifications. Unfortunately, this is something just to memorize. So you have the New York Heart Association, NYHA classes, which is 1, 2, 3, and 4. Where 1 is no limitation on function or physical activity. Class 2 is slight limitation with ordinary physical activity, you start to have problems. Class 3 is there's marked limitations of physical activity, but less than ordinary activity tends to cause symptoms. And then severe class 4 is you're unable to do any kind of physical activity, and you're having problems at rest. The AHA-ACC stages, go from A to D, A being just at risk, or there's risk factors for it, but no symptoms, no structural or functional abnormalities related to the heart. Stage B being that there are now structural functional problems with the heart, but they are asymptomatic. Stage C is you still have those structural functional abnormalities, and now they're having symptoms. And then stage D is they have those abnormalities and they continue to have symptoms in spite of medical therapy that they're already on. Once you're able to identify what their stage is, it allows you to kind of see what's the appropriate treatments. So I will again provide these to you. We did practice on Wednesday with them, but I will provide these. So stage A is basically just mitigate the risks. Let's prevent the heart from declining or deteriorating any further. Stage B, now you do have some treatment algorithms, particularly when the EF gets less than 40, and now they are officially given the diagnosis of HFrEF. So ACE inhibitors and beta blockers are your primary treatments. You would only give an ARB if they're ACE intolerant. So if they have not been on an ACE, if they have not been on an ACE inhibitor before, you don't start them on ARB unless there's some kind of documented reason for an intolerance to ACE inhibitors. Stage C and D. So this is going to be your goal-directed medical therapy. That's what GDMT stands for. It's goal-directed medical therapy. And really kind of focus on the ACC-AHA staging to be able to clearly identify somebody to be in this. The first step that you're going to do once they have gotten to stage C is you're going to start them on goal-directed medical therapy, which are going to be these medications. ARNI is preferred over ACEs and ARBs, but if there's a reason that they cannot be on an the ARNI, then go ahead and do the ACE or do the ARB instead. But they should be on a beta blocker, they should be on a mineralocorticoid receptor antagonist, they should be on the SGLT2 inhibitor, and then just diuretics as needed. Once you have maximized that treatment, the dosing and everything like that, once you've maximized that, step 2 is let's assess response. Did they have an improved ejection fraction where now it's greater than 40? Great, we'll just continue and go down this line and continue with lifestyle changes. Let's continue the medication dosages and continue to monitor them. But if they still have an EF less than 40, now they are considered persistent HFrEF. And now you're going to do step 3, which is look and see if they meet any of these criteria. Are they African American patients? Are they EF of less than 35 without a bundle branch block or left bundle branch block? Or are they an EF less than 35 with a left bundle branch block? And if they are, then let's go to step 4, which is if they're African Americans, let's give them hydronitrates. If they're EF of 35 but no left bundle branch block, we're going to put an ICD in. If they are EF of 35 with a left bundle branch block, you're going to do that cardiac resynchronization therapy with the defibrillator with it. So you're going to do those, and then you're going to reassess. Did we make any improvement on their EF? If symptoms are improved, great. They just will continue everything that we've done, and we'll just continue to monitor. But if they are still having symptoms, especially if they are debilitating symptoms, then they are considered stage D, and you go to step 6, which is doing the mechanical circulatory support devices, doing heart transplant, or talking to them about palliative care. I know that's a lot of lines on that.
I have a question, sir.
Yeah.
With that being said, with the middle row of green boxes, we can't do anything there until we've completed everything on the far left. Is that correct?
Ideally, yes. Because hopefully, you're not having to do some of the, hydronitrates are not invasive, but you're not having to do like a pacemaker or a defibrillator in somebody who, I just need to put them on medicines and optimize their medicines, and now their EFs are greater than 40. So ideally, you will maximize that. There are situations, like even in stage B, if their EF is less than 30%, you're putting the ICD at that point. So it could be that they were EF less than 30 asymptomatic and you got the ICD, and now they become symptomatic. Now they're stage C. You've already done that while you still have to do the medicines. So, yeah. Okay. And then you all know these meds, what they do, but relate in particular to in particular to heart failure. ACE inhibitors have been shown to increase survival, so there's a mortality benefit to it, and it reduces the remodeling of the heart muscle itself, so it kind of preserves the muscle that is there that's not damaged. Same goes with beta blockers. Again, it has a mortality benefit to those patients. Key thing being though, not to start these if they are in acute decompensated heart failure. So if they already got progressed to that point, you're not starting them at this point. You're going to let that acute decompensation get treated, managed, and then you'll start these medicines. The ARNI, the sacubitril valsartan, the angiotensin receptor blocker neprilysin inhibitor, is great because not only do you get the ACE-ARB benefits, the mortality benefit from that, the reducing of the remodeling, but you also get all the benefits associated with the neprilysin inhibitor, which encourages the natriuretic peptides, higher amounts of those, and all the positive benefits associated with that. And ultimately, it also will reduce remodeling of the heart. And that's why, kind of getting a 2-for-1 deal on this, so that's why it is preferred that once they get to stage C, you're starting them on the ARNI instead of just an ACE or just an ARB. Diuretics, although they do improve symptoms, there is no mortality benefit. So unfortunately, if I'm giving you options on which medicines will help with mortality benefit, diuretics are not the answer. Mineralocorticoid receptor antagonists, the MRAs, the eplerenone and spironolactone are our two main options for this. It does have a mortality benefit, it does improve symptoms, and it does decrease hospitalization. So there is a benefit, a mortality benefit to patients being on these meds. And then we talked about SGLT2 inhibitors. These also have a mortality benefit. So they reduce the risk of MI, stroke, and cardiovascular death. And then for African American populations, the isosorbide dinitrate hydralazine combo is indicated if they meet this criteria here. And then we talked about ICDs and CRTs if they meet that criteria. If they continue to have symptoms in spite of all of that, all the medicines being optimized, although the ICD, CRT, whatever being implemented, they're still having symptoms, then they are considered stage D, and you're starting to think of the mechanical circulatory support, so like the LVADs, the left ventricular assist devices. You're thinking about transplantation, heart transplantation, or thinking about end of life kind of decisions. Other things with your heart failure patients, so you want to prevent them from developing, a high output heart failure, so like an infection, so they're going to need their vaccinations to prevent those viral infections, bacterial infections. You're going to monitor for thyroid disease because any kind of abnormality in the thyroid hormone can lead to a acute decompensated heart failure. And then key thing, except for aspirin, they are on NSAIDs. They need to stop them immediately. And then your diltiazem, verapamil, you want to avoid those meds in heart failure because there is no benefit to them being on those meds. Then we talk about HFpEF treatment. So not a lot of great evidence as far as medications, med management. The only thing that has been shown to have good benefit is diuretics as needed. There is rising evidence of SGLT2 inhibitors in the treatment of HFpEF, but more studies are necessary for that. But otherwise, there's not a great medication regimen to give somebody with HFpEF that has good proven studies to show benefit. If they have acute decompensated heart failure, remember you have to delineate what kind of picture they are presenting with, whether it be warm and wet, cold and dry, or cold and wet. And that basically means if they are wet, there is signs of congestion. So could it be pulmonary edema, crackles? Could it be JVD, increased peripheral edema? Looking for those types of symptoms to suggest them being volume overloaded and wet. If they are cold, be thinking of conditions that cause low perfusion. So basically, you are not getting the blood circulating around like it should. And you're going to get things like cool extremities, symptomatic hypotension, cyanosis, those kinds of things. But cool extremities tends to be a significant kind of differentiating symptom. Diuretics, so the loop diuretics tend to be your main option to treat this. If you need ionotropes, so dopamine and milrinone are your two options. So just doing either one of those will help. And then we go back up a couple of slides. Sorry, I'm going to go the other way to our chart here. Once we've classified what picture we're looking at with our patient, if they are warm and wet, so they are perfusing but they're congested, it makes sense that diuretics are going to be our mainstay of treatment. You may do vasodilators to help with that. If they are cold and dry, so they're not perfusing, it's not necessary. It's not a congestion fluid overload problem. So you just want to improve the perfusion by giving them ionotropes, and then also vasodilators. If they are cold and wet, so now they're not perfusing, and now they also are congested, and they have extra volume, you're going to be doing diuretics to get rid of that extra volume. You're going to be doing ionotropes to improve the cardiac output, the perfusion, and then vasodilators to help with perfusion and blood circulation in general as well.
Sir, for drugs, half-lives, MOAs, are you interested in us focusing on that? Or?
No. I think you got enough of that in farm. I won't test you on that. So I got enough else I can test you on that doesn't involve mechanisms of action. So, but yeah, just know which drugs are considered diuretics and which ones are considered vasodilators. So, sorry, let me go go back forward. So, okay, questions about heart failure? Okay, we are 4 lectures down of our 6, so we got 2 more lectures worth of material to cover. Cardiomyopathy. So this is a syndrome of conditions, muscle disorders that are not attributable to other cardiac problems. And what I mean by that is there's not a heart valve problem that leads to a cardiomyopathy. It's usually something completely different from that. So there's 3 main types: the dilated cardiomyopathy, the hypertrophic cardiomyopathy, and the restrictive cardiomyopathy. Dilated cardiomyopathy. Lots of things can cause this. Idiopathic, we don't know what caused it. It tends to be the most common cause for it, but things like viral infections, alcohol toxicity, other toxins can also cause the development of this. And with it, be thinking that this is a systolic dysfunction. And basically what happens is you get a decreased contractility because the heart muscle is being stretched too far. You down and get the extremes of the Frank-Starling curve, and you can't get that effective squeeze, so your stroke volume starts to deteriorate. So you get decreased cardiac output, you get increased ventricular filling pressures that will then cause a backup into the lungs or into the systemic venous system. But also because of that dilation of the heart muscle itself, you start to pull the valve leaflets away from each other, particularly like mitral valve if it's the left ventricle, and now you start getting a mitral regurg, and now you start to get all those pathophysiologic effects of mitral regurg in addition to the problems that we already are having. Tends to affect younger folks, so folks that we typically are not thinking of heart disease being common, typically if it's affecting the left side of the heart, we're going to have left-sided heart failure-like symptoms. EKG, you're going to see left atrial dilation, left axial deviation. LAD is left axis deviation. You're going to see left ventricular hypertrophy. You're going to see the conduction blocks because of basically the stretch and the strain that's happening on the conduction system, and they may have arrhythmias related to that as well. Echo is going to be a test of choice, and you're basically in dilated cardiomyopathy. You're going to see all 4 chambers are enlarged with this. So unlike let's say like an aortic regurgitation where you're only seeing left-sided dilation, with dilated cardiomyopathy, it tends to affect all 4 chambers. There tends to be this global hypokinesis, so the function of all of the chambers is decreased because of this. How do you treat it? Well, let's try to increase our stroke volume. So how can we increase our stroke volume? Well, let's reduce that excess preload to try to restore that Frank-Starling curve and make the squeeze more effective. Let's reduce our afterload so that our stroke volume will increase just by reducing the afterload. And let's see if we can increase our contractility. So we kind of hit all 3 of the components that affect stroke volume. And then the dilation of the chambers themselves can also lead to problems. So let's manage the arrhythmias with the amiodarone. Let's reduce cardiac remodeling with ACE, ARBs, or ARNIs, beta blockers, and aldosterone antagonists. If they're having arrhythmias, then they need to be on an anticoagulation so they're not developing blood clots and throwing blood clots and causing embolic disease. And then if function is severely declined or diminished, then they may need much more invasive procedures, treatments to manage this. What's the prognosis? It really depends on what the cause is, but typically if your heart is failing that bad, life expectancy, if it doesn't rebound on its own without surgery, is very bad. You can, yes. Yep.
And the other thing was,
Mhm.
is that together, or is that in reference to, is it less than it is?
So because it affects all four chambers, it doesn't necessarily mean it's going to affect them equally. So if you do get enough of a dilation of the right side, then you can get the tricuspid regurgitation associated because you're pulling those leaflets apart. The left tends to be more affected from this, so that's why you tend to see the mitral regurg more prominently.
So would it be that the ventricles are more affected, and that's why you're giving the mitral and tricuspid as opposed to the pulmonary?
Yes, yeah, because you're not necessarily like for aortic and pulmonic to be regurgitated, like you get the regurgitation associated with that. You're thinking of like the aortic ring being impacted, and it's not getting up to that point where you're getting that backup of volume to cause that dilation. And then the pulmonic artery itself, just think of it, typically it won't cause that dilation of the artery. Now, to kind of complicate things, if that regurgitation, extra volume and extra pressure on the left side is bad enough, and then it goes up into the lungs, and then that goes from the pulmonic veins now down to the pulmonic artery, it could cause that. So you may start to see pulmonic regurg. But that is maybe a little more complicated than we would want to be tested on. Yeah. Okay. Okay. Stress cardiomyopathy. Remember, this is a version of dilated cardiomyopathy. But the key thing with this is, instead of all four chambers being impacted and having like this global hypokinesis, we typically think of this as only affecting the apex of the heart, where there's that ballooning of the heart. Typically, think of this in developing in patients who have this increased sympathetic stimulation, like a severe emotional distress, like the death of a loved one. They have severe health issues that leads to this happening. Typically, folks, when they have this, are going to look and smell and breathe like an acute myocardial infarction, but when you do the echo, you're going to see that apical ballooning. And that's why you're going to do the echo. Treatment, basically you're going to manage the complications, the consequences of this condition, but it is self-limiting. There's not like a specific medicine that you give to them to improve function or improve this condition specifically. We'll just I don't know what's going on. I can hear myself now. There. Hopefully you can hear me. I think the mic is getting worn out. Yeah, so this is a self-limiting condition. Just manage the complications, the symptoms that are associated with it, and then it should go away. It should improve on its own. And then one additional thing to think about, because this does tend to develop in like that severe emotional reaction, they may benefit from things like anti-anxiety medicines. But the clinical vignette with this is going to describe some kind of emotional trigger that led to this. So, hypertrophic cardiomyopathy is the next one to talk about. Hypertrophic cardiomyopathy is different than left ventricular hypertrophy in that instead of the whole ventricle itself being enlarged or hypertrophying, especially symmetrical, it is this asymmetric pattern of hypertrophy, and classically it's going to affect the septum of the left ventricle. This is a diastolic heart failure as opposed to what we were just talking about with dilated cardiomyopathy, which was a systolic heart failure. This is a diastolic. There's really two kind of pathophysiology branches to this, what you're going to see. So the hypertrophy of the myocytes are going to lead to left ventricular hypertrophy, which is going to then lead to causing problems in the lungs because of the extra pressure that builds up that will communicate to the lungs. It's going to increase their oxygen consumption, so they're going to get like chest pain because of that supply-demand mismatch. Because of that, the hypertrophy tends to affect the conduction system. They are prone to getting arrhythmias, which then can cause either syncope because of the abnormal rhythm, reducing the cardiac output and all that, or sudden death because they get that acute arrhythmia that is not compatible with life. That's the one branch. The other branch is if you have this obstructive component to it, so now you have that outflow through the aorta is being obstructed, you will get increased systolic pressure because of that, because the blood's not being allowed out of the ventricle because of that obstruction, which then can lead to increased oxygen consumption and lead to an angina. But you can also then get reduction in your cardiac output, which is going to then give you those exertional symptoms. And then remember the Venturi effect, where it can also lead to mitral regurgitation because of the Venturi effect is going to open that mitral valve inappropriately. And now instead of blood going out to the aorta, it's going to want to go into the left atria. So what are you going to see? Well, you're going to see exertional symptoms. Well, often, most people are asymptomatic. But if they are going to have symptoms, it's going to be exertional kind of symptoms where they're short of breath, they're passing out, or sudden cardiac death. Either because of an arrhythmia that just developed or that acute blockage, basically, or the outflow obstruction prevents them from meeting the perfusion demands. What are you going to hear? Because the best way, and the only way we really have to screen like our young athletes is history and physical. So what are you going to hear? Well, you can get this crescendo decrescendo murmur at Erb's point. Systolic, there's your other option that you need. So systolic, crescendo decrescendo, Erb's point. You may have a whole low systolic murmur with that mitral regurg if mitral regurg is present. You can do dynamic maneuvers to help you kind of differentiate this from other murmurs if necessary. And remember, things that increase the intrathoracic pressure, that decrease the venous return or decrease that preload, tends to make the murmur worse. If you increase the preload or that venous return, you decrease the murmur, which is different than most cardiac murmurs that you hear. EKG, you're going to see the left ventricular hypertrophy, you're going to see the left axis deviation, and then of course if they're having any kind of arrhythmias, you may see those on EKG. Echo is going to tell you exactly the diagnosis because you're going to see this asymmetric septal hypertrophy or asymmetric hypertrophy in general being present, and then it's going to be allow you to kind of test some of the consequences and complications associated with hypertrophic cardiomyopathy. Chest X-ray, maybe normal, maybe left atrial enlargement if it's significant. If you have significant mitral regurg present. MRI can help you, but usually the echo is going to be your test of choice. How do you treat it? Well, avoid volume depletion, so avoid dehydration, extra urine loss. Avoid overexertion. You're going to want to do things like beta blockers and the non-dihydropyridine calcium channel blockers, because this will increase diastolic filling time, which then will add more volume to the ventricle, which will help with preserving cardiac output, because that obstruction, that closure may not happen until later in the cardiac cycle. Other things you're going to want to do, you're going to want to maintain that afterload, because you want to kind of have that backward pressure that kind of keeps the obstruction from happening. And then decreasing contractility with like beta blockers and the non-dihydropyridines. Basically, because you're reducing that contractility, it's not going to squeeze as hard, so you're not going to get as much of an emptying effect of the ventricle with it. So again, it will maintain that opening, so you're not getting that outflow obstruction. And because of the risk of arrhythmias, you're going to put them on the antiarrhythmics. But the gold standard for these patients is to do a procedure or surgery, which the septomyomectomy is the typical one, but there is some less invasive procedure that is coming down the line that may be better, because you're not having to do an open heart surgery for it. And then we talked about the only way really to screen for these people who may be at risk for it is history and physical. Yeah. Restrictive cardiomyopathy. So this is the last cardiomyopathy. So again, this is a diastolic cardiomyopathy. That results in like a stiffening or fibrosis of the ventricle wall itself. So you get a decreased compliance associated with it. So it's not going to want to take on a large volume of blood. So your preload is going to drop. Lots of things can cause it, but be thinking of like the deposition diseases like amyloidosis, sarcoidosis, hemochromatosis. Folks who've been exposed to radiation chemotherapy tend to be at risk for developing this as well. And what happens with it is, because you have decreased preload, you get that decreased filling, that's going to result in decreased cardiac output. You're going to have those exertional kind of symptoms. Because you also have that increased diastolic ventricular pressure. Because of that reduced compliance of the ventricle, it's going to lead to backing up into the atria and backing up into either the lungs or the systemic venous system, or most likely both. What are you going to see? Well, you can see Kussmaul's sign. So remember that increase in the JVP with inspiration, that's Kussmaul's sign. That's counter what you would normally expect with inspiration. On EKG, you're going to see a low voltage. Chest X-ray, you may see just complications associated with the condition itself. Echo is going to, especially if it's an infiltrated disease, you're going to see this starry night or speckled pattern on it. That's going to be kind of the classic finding to help you with this. This is one of the few cases where cardiac MRI is actually useful. So it helps you differentiate restrictive cardiomyopathy from constrictive pericarditis. So something that we learned in the first block. The biopsy of the heart muscle itself helps tell you exactly which version or what's the cause of the restrictive cardiomyopathy. How do you treat it? Well, let's do preload reduction with salt reduction and diuretics. Let's reduce our afterload to try to help preserve that stroke volume. Let's do anticoagulation if they have an arrhythmia. And ultimately, these folks, because this is a progressive disease, it tends to be a progressive disease, these are folks who are going to need a heart transplant. And you can see Mortality is usually within 1 to 1.5 years if they have severe disease. Questions about cardiomyopathy? Got 10 minutes to keep you on time. So, last lecture was kind of a catch-all. So orthostatic hypotension was the first thing we talked about. The definition of orthostatic hypotension is drop of 20 millimeters of mercury in the systolic blood pressure, or a drop of 10 in the diastolic pressure at least 3 minutes after standing. So compare the laying to the standing and see if you get this criterion met. Usually there will be people who have like dizziness, presyncope, or syncopal episodes, and it could be due to things like volume depletion, like they're dehydrated from like an illness, or medications contributing to this. This is something that is common in the elderly because they cannot regulate their blood pressure as efficiently and adequately as younger folks can. So the body is slower to adjust to gravitational pull. If they are on, especially multiple medications, it can cause them to have this. If they are consuming too much alcohol, it can cause this. And then there's lots of other medical conditions that causes like affects like the central nervous system and such, and the heart's ability to adjust. Labs. Basically, you're focusing and trying to figure out what is the cause of their orthostatic hypotension, especially if it's like an acute thing that they've never been seen for. You're looking for signs like they're anemic or they're dehydrated, the kidney function's not working right. Rule out hypoglycemia and those types of things. The treatment, so if you can find a cause, go ahead and treat it. So if it's they're dehydrated, great, maybe they need IV fluids. If they're on too many medicines that are interacting with each other that's causing this, okay, let's see if we can pull off some of those meds. And then maybe we need to do some exercises before we get out of bed so the heartbeat speeds up before it's having to adjust to gravity. Maybe we need to do things like tensing muscles and stuff like we're standing up to improve that preload or increase that afterload so we're preserving blood pressure. But if those things are not working, you can't find a cause to address, then let's do fludrocortisone or midodrine. That's kind of our primary treatments. If it occurs after they eat, then maybe octreotide might be helpful to them. Syncope. This is a abrupt, transient loss of consciousness due to a global cerebral hyperperfusion, so the whole brain perfusion is being impacted by it. Compare that to a stroke. And they have a rapid, spontaneous recovery. So they don't have like a post-ictal period like you do with seizures. Most commonly, vasovagal syncope is probably the most common cause for this. So vasovagal syncope is a neurocardiogenic syncope that ultimately involves a hypotension and a bradycardia, where basically the vagal nerve stimulation, excessive vagal nerve stimulation, causes that parasympathetic stimulation, which slows the heart rate down, and then it also impacts the blood vessels, and you get this vasodilation, which will cause a drop in blood pressure. But usually there is some kind of predictable trigger for it. Arrhythmias are another cause of syncope, and it's not a specific one. There's all kinds. It basically just affects the blood perfusion of the brain because of that arrhythmia developing. And typically you're going to do some kind of EKG or a continuous monitoring to try to figure out what arrhythmia is present so you know how to treat it and manage that arrhythmia to prevent it from happening again. Seizures can cause this, but they tend to have this post-ictal phase, so after they come to, they're confused, they don't know what's going on and everything, unlike just a vasovagal syncope where they are aware of what happened, know where they're at and all Hypoglycemia can cause it. Great. If it's low sugar, let's give them sugar. The output, so cardiac output's decreased. So they're going to have kind of the symptoms we talked about with the exertional kind of symptoms having this, which there's lots of cardiac causes for it. There's including some pulmonary ones, but cardiac causes tend to be the most common cause for output issues. Unusual, so psychiatric conditions can cause people to have syncope. Transient, so this is going to be like particularly like strokes in certain areas of the brain that causes a hypoperfusion, can cause a syncopal episode. But most strokes do not cause syncopal episodes because you don't get that global loss of perfusion. But if you do have this, okay, do head imaging, see if you can find where the perfusion is being impacted so you can help with treatments. But your history is going to be the beach, going to the beach. So what happened before the syncope happened? What did eyewitnesses see, do? What happened after? What were the circumstances that led to this happening? And have you ever had this happen before? Let's look at our history. Treatment's going to be specific to what the cause is, but maybe they need to be on midodrine, maybe they need fludrocortisone. If you can't find a specific cause and address it with that. Then we talked about shock, which these are life-threatening conditions due to inadequate perfusion of vital organs. And there's 4 main types of shock. Cardiogenic shock, think of this as something that develops after a heart attack, especially like an anterior wall heart attack, where there is a large amount of heart muscle that is damaged or killed because of the heart attack, which then kind of puts you in this downward spiral where the needs are not being met, and then it continues to cause worsening of your shock, and then leads to death if not treated quickly. So we're talking about anterior MI, usually like in a STEMI. Yeah, just evidence of organs failing, hypotension as being kind of clinical presentation for it. With treatments for it, you're going to want to try to improve contractility so you're not in that death spiral, right? And then also you're going to try to improve their blood pressure. So we're going to put them on vasopressors and inotropes to be able to do that. If they're not responding, then there are the mechanical devices like intra-aortic balloon pumps that can be placed into the aorta to help with cardiac output. Then we talked about distributive shock, which is basically septic shock, anaphylactic shock, and neurogenic shock. Think of this as conditions where there is a capillary leakage of volume. So you end up getting a decreased intravascular volume, which decreases your preload, and you ultimately get a decreased cardiac output because of it. Septic shock, you're going to see signs of infection that's present. It's anaphylactic shock. It should be either the food consumed or history of animal stings, bites, and those types of things that triggered the anaphylactic reaction. Labs directed based on the cause. So if you have a septic shock picture, you're going to be looking for signs of sepsis and what the bacteria is that caused it. Treatment's going to be based on the cause. So if it's sepsis, you're going to need antibiotics, fluids, and vasopressors to support blood pressure. If it's an anaphylactic reaction, you're going to be doing EpiPen, steroids, antihistamines, and then further avoidance of whatever triggered that to happen. And then neurogenic is going to be whatever the cause is. Hypovolemic shock, 2 types. You have hemorrhagic and non-hemorrhagic shock. So hemorrhagic shock, okay, trauma, lose a lot of blood. Let's treat it by giving blood and treating whatever the bleeding issue is. If it is non-hemorrhagic shock, let's do if it's like severe dehydration, let's give them volume. Ultimately, the pathophysiology of this is decreased volume leading to decreased preload to decreased cardiac output. Yeah, and we talked about how you treat it. Obstructive shock was the fourth and final one. This is where there's an obstruction of the great vessels of the heart, whether it be something inside of it or something external to them that is impacting their function. So you get the obstructive condition that decreases your preload, it increases your afterload, which ultimately leads to a decreased cardiac output. So this could be things like a pulmonary embolism that's preventing blood flow out of the right side of the heart and into the lungs for oxygen, carbon dioxide exchange. What are you going to do? Well, labs, you're looking for like a cause for it, potentially. EKG, non-specific kind of findings. Echo may visualize the actual obstruction, so if it's like a cardiac tamponade, or you see like increased pulmonary hypertension, then you may have an idea of what it is. And then the way you treat it is, let's try to manage their blood pressure to kind of restore it a little bit with fluids or pressors. Let's treat respiratory distress with either intubation, giving them oxygen, those kinds of things. And then if it's an acute obstruction, like a large PE, let's either go in and get rid of it, or let's give them TPA to break it up and get rid of it, and restore that flow in the pulmonary artery.